I'm going to be covering diffuse intrinsic pontine gliomas, or DIPG. So, etiology of DIPG. DIPG is a tumor in the pons of pediatric patients. There are three known mutations that can lead to DIPG. You can have a silent mutation, a mutation of the MYCN gene, or a mutation of the H3F3A and histone 1H3B genes, which causes a mutation in the histone H3. The mutation of the histone H3 causes a replacement of lysine at amino acid position 27 with methionine, and this mutation is referred to as the H3K27 mutation. The H3K27 mutation accounts for about 80% of known DIPG cases. This will lead to significant disruption of the epigenetic programming and signaling, which will change the way the glial cells grow and divide, and lead to uncontrolled proliferation and cell determination, which leads to the diffuse tumor in the pons. So about clinical presentation, it is a very rare cancer. Only about 150 to 300 kids get diagnosed per year in the US. The average age of diagnosis is about 5 to 7, as you can see in the graph that I've placed on the screen. There's a very wide variety of symptoms, but in about 50% of patients, you'll have cranial nerve palsies, which is represented by facial asymmetry and diplopia, long tract signs represented by hyperreflexivia and the upgoing Babinski sign, and then cerebellar signs are represented by ataxia and dysmetria. These three symptoms, cranial nerve palsies, long tract signs, and cerebellar signs, are referred to as the classic triad for DIPG. So if you get a pediatric patient that presents with all three symptoms, you should immediately be suspicious of DIPG and run diagnostic imaging, which is usually a CT without contrast or an MRI. Given that DIPG progresses very, very rapidly, it's usually about 1 month from the onset of symptoms to the time of diagnosis. And at about 10% of kids at the time of diagnosis, they present with obstructive hydrocephalus. But obstructive hydrocephalus is usually a sign of the end stage of DIPG, so it's a very unfortunate symptom to have and present with. So prognosis for DIPG is incredibly dismal. Overall, for pediatric cancer at 5-year survival rates, you have an 83% survival rate, but for DIPG, it is less than 1%. Surgical resection is not an option due to the diffuse nature of the tumor and the location being in the brainstem, so surgical resection and biopsies are both not viable options for treatment of DIPG. And there's a less than 10% survival mark at 2 years. So at 2 years, less than 10% of kids with DIPG survive. At the time of diagnosis, the average survival rate or survival time is from about 8 to 11 months. The literature kind of varies, but 8 to 11 is the most agreed upon time frame for time of diagnosis to time of death for kids diagnosed with DIPG because it is so rapidly progressive and severely debilitating. About 89% of parents who had a child with DIPG who's passed reported distressing symptoms within the last month of life. And the distressing symptoms are things like loss of consciousness, breathing difficulty, impaired mobility, dysphagia, that kind of thing. So current treatments, because the prognosis is so incredibly dismal, a lot of times whenever you diagnose DIPG, you will consult oncology and then consult palliative care. So you treat the symptoms for a lot of DIPG. You try to make it as comfortable as you can. There are a few drugs for DIPG on the market. There's an anti-GD2 CAR T therapy that they're coming up with. The idea is that you take blood and T cells from the patient, you create CAR T cells in a lab, grow a bunch in a petri dish, and then infuse it back to the patient. The CAR T cells will then bind to the cancer cells and cause apoptosis or kill off the cancer cells. It is a very good theory. However, in animal models, it causes obstructive hydrocephalus, which is very lethal, especially with DIPG. So major kink to work out there, but there's definitely some promise for that kind of therapy. A lot of medication right now is TMZ. It's used concurrently with radiation, but no studies have demonstrated a clear role in the setting of DIPG, but it's used for other pediatric gliomas, so a lot of times it gets given to kids with DIPG. It's hard to study due to the poor prognosis. Not a lot of parents want to enroll their kids in clinical trials because of limited time left and the possibility of causing more pain. So not a lot of clinical trials going on for DIPG. But out of all the papers, they all tend to agree that there's a need for improving delivery of drug across the blood-brain barrier for the best results for DIPG drugs. And this is my bibliography.